Good afternoon, everyone, and welcome to this perfweb.us, perfusioneducation.com special program. I am your host, Joe Basha. I'm going to take about the next 10 minutes or so while they're getting everybody all organized and up on the Skype so we can bring them in. And I want to talk to you about some things. As this program is airing, there is positive news. Hospitalizations in general and ICU admissions in New York have dropped 5 days in a row now. Testing, treatments, and vaccines are moving forward at a record pace. Soon, this nightmare will be over. We will not have our professional lives consumed by this one disease, and we will all be seeing elective cases again. I worry a lot about how many people may have fallen through the cracks because all focus has been on COVID-19. However, what are the lessons here? The obvious lesson is that we are woefully ill-prepared. Ill-prepared with equipment like ventilators, ECMO platforms, PPE, bed space, medicines, and even the trained, experienced professionals to run all these complex systems. Interestingly, compared to H1N1 in 2010, the use of ECMO has been very light. I'm not sure why, but I am grateful for this because I don't believe anyone would disagree with me that there are simply not enough ECMO platforms, circuits, perfusionists, or specialists available should we have another virus that causes respiratory or cardiac failure. That short-term, 5 to 30 days of support would save those lives. In particular, if it afflicted a younger, healthier part of our population that would be excellent ECMO candidates with a high probability of recovering fully. So it brings up this central question, and this is meant not just for my perfusion colleagues, but any stakeholder that may be watching this. What is our strategy for the next epidemic or pandemic? There are some perfusionists that argue, quite passionately, that only perfusionists should operate ECMO. Unfortunately, there are simply not enough of us on a national level. Now, the big centers with internal programs, see, they can say that. But all the community hospitals with 1, 2, or even 3 perfusionists, and there's a lot of those people would be overwhelmed quite quickly. Imagine being in a sole perfusion practice or even a 2-person program. There are a lot of those too, and you have 2 heart-lung machines and 1 backup centrifugal pump. How's that going to work when you have all of that being used for ECMO? So what do you do when a STEMI rolls in with a 99% left main and significant proximal LED circuit RCA lesions? Will you be at work for 24/7? Do you just do 12-hour shifts? What if one of your team gets sick with the very disease you're treating? We have historically avoided really examining this and those issues and have always seemed to get by. Eventually, however, I feel it is going to catch up to us. It is never as simple as, well, we'll just buy a bunch of ECMO pumps and leave them sitting around. Firstly, they are really expensive, and second, the single-use blood circuits and oxygenators have expiration dates, and those too are very expensive to just have around for a what if. We're going to just hire a bunch of perfusionists and just have them all sitting around? It's a recipe for financial disaster, and we know we can't afford it. No hospital can, no system can, no company can, nobody can. So what is the solution? What do we need to do? How will we manage this? Several things, in my opinion, need to happen before the next crisis. 1, we need to compel industry to create an ECMO platform that is simple to use and affordable. 2, we need to develop well-designed, efficient ECMO specialist programs with continued simulation competencies so that when, not if, a disaster strikes, we have enough people to manage these systems in a safe manner. We need to be selective with whom these people are that get trained. My vote is ICU docs, ER docs, anesthesiologists, and critical care nurses. Those are my first choice. And I am not talking about Mickey Mouse training. I'm talking about high quality, comprehensive training that really prepares people. And you know what? It might not be used by everyone that gets trained at first, so you need yearly competencies and refreshers. But in a real disaster, another real disaster, if we do this, there will be enough people that have at least some level of comfort and familiarity that can step up and help to monitor these systems in patients. 3, we need to embrace nanotechnologies that can add meaningful oxygen carrying capacity without the need for homologous red cell transfusions. Our blood banks are strained to the limit. There's a shortage of blood. We need to adopt telemonitoring to facilitate care of multiple patients with one seasoned, experienced practitioner that can give direction to the clinicians at the bedside, the nurses at the bedside, the ICU doc at the bedside, the anesthesiologist at the bedside, the CRNA at the bedside, whatever it may be. Mostly, we need to solve this problem together. The days of territorialism are over and should never have been here to start with. We need to see how we can process convalescent plasma faster. Could perfusion be involved in this? You know, Bill Gates recently said that if anything is going to kill millions of us, it will likely be a virus and not a war. You know, pretty prophetic words, but a pretty smart guy. Perfusion is a wonderful profession, and I do believe we should be driving change and the solution. We should be doing the training, oversight, competencies, renewals, and leading the charge for the development of simplified systems that are effective, safe, and affordable, because there is no doubt this will happen again. I am in no way advocating for perfusion to relinquish our involvement in ECMO to others. Bottom line, I believe perfusionists are, by virtue of our training and daily experiences, the group best equipped for overseeing this critically important therapeutic modality. While we are waiting for the various folks to get logged in, and I think we're getting close, let me take a few more minutes of your time to tell you why I am doing this, especially in light of all the programs going on right now. I have watched quite a few of them, and some were great, some maybe not so great. I feel that we, and I am talking about the show, are very careful about what we present. We strive to be fact-based and objective, keeping with the highest of evidence-based standards. It is an opinion, if it is an opinion rather, we make that clear. We also work really hard to bring real experts to the program and also to bring a program to you that is enjoyable to watch. These times have made that even more challenging because of social distancing measures, not to mention how busy we all are. Doing an entire program over Skype or another similar service requires a lot of coordination. Not everyone has a studio in their office or at their home. At the end of the day, we know you have a ton of choices from which to earn your CEU. We are always trying to be better because we want you to consider us the most effective, enjoyable, and affordable place to earn those CEU. And we want to definitely thank you for your continued loyalty. Over the next month, we will go on with the Corona 30 PerfWeb programs. These programs have been divided into 3 10 CEU sections, for a total of 30. Later, we will be developing new content, some of which will explore the lessons we have all learned from this trying time. So let me save a little bit of time and introduce who is going to be on our program today. Moderating with me, so the co-moderator, will be John Ingram. You all know John from many of our programs, and he is a practicing perfusionist currently working in Florida, in fact, at a very big ECMO center. He has firsthand knowledge and experience with COVID patients on ECMO. From Mount Sinai in New York will be Dr. Robin Varghese, Associate Professor, Cardiovascular Surgery, and also the System Director of Cardiovascular Critical Care. With Dr. Varghese, or coming from the same location is Praveen Mudumba, good friend of mine, great guy, who works with Dr. Varghese and who is right now in the trenches, literally on the front lines. From St. Luke's, the Woodlands Hospital, the Woodlands, Texas, we have Dr. Jeffy Matthew, Clinical Assistant Professor of Medicine, Baylor College of Medicine, and Regional Chief Suburban Hospitals, Pulmonary and Critical Care Medicine, and the Director of Intensive Care of the Intensive Care Unit, at CHI St. Luke's Health, the Woodlands. And perfusionist Patrick O'Toole, who was the lead perfusionist on what was the first use of ECMO for COVID-19 in the Houston and Greater Houston area. So Dr. Matthew and Patrick were both involved in that case. Dr. Matthew for making the decision to put the patient on ECMO, and Patrick was the lead perfusionist for that. And coming to us from the Texas Medical Center, Dr. Haney Samir, Assistant Professor of Cardiac Surgery, Critical Care, Transplant Quality, Houston Methodist Hospital, but is here today participating in today's program as the CEO of HS Consulting, which is a tele-ICU, tele-ECMO services company. So I think I got everybody done. Yes?
You have to tell them one of them is sharing the screen.
Oh, well, I don't know who it is.
Probably Dr. Matthew.
Dr. Matthew? Oh, okay. So, oh, Dr. Matthew, could somebody over there is sharing their screen, they're telling me, so if you could just stop share, make sure your screen isn't being shared. With the little icon. The bottom. Bottom right. Okay, everyone, we promise we'll be right with you. Did they get it? The one next to the beating heart. Is it Patrick? Is it somebody else? Is it John? Getting close, whoever it was.
Click that, yes.
Click that, yep. Was it John?
I don't know.
No, I don't know. Okay, so real good. Okay, so can we bring everybody up? Can we bring everybody up?
No, they're going to come up one at a time.
Okay. Okay, so John, very quickly, for everybody that's out there listening, we're going to have a clock. I'm going to turn this over to you, John. We're going to have a clock, and that clock is going to be set at 10 minutes. So each person is going to have 10 minutes to go through their thing, and they'll be able to see their time as we're moving forward with this. And then at the end, we'll have a 10-minute Q&A session. So my good friend, John Ingram, you take it away.
Well, welcome everyone. I hope everyone's doing well. I see everyone very well on the screen, so looking forward to a wonderful webinar today. The first question is for Dr. Varghese. You're at Mount Sinai there in the front lines of New York, and up to date, how many COVID cases have you seen thus far in your ICU?
So we're an 8-hospital system, and at the main campus, we have 120 ICU beds normally. Right now at the main campus, we have 240 patients that are in ICU beds throughout the main campus. Throughout the hospital system, we have about 340 patients that are admitted to intensive care units.
And in the last few days here, are you seeing a growth, or do you think you're seeing a reduction in your ICU admissions for COVID patients?
It seems to be, just as the governor of New York has stated, it seems like we're starting to likely see a plateau in the last 48 hours. The trend is not long enough for us to confirm that, but we are seeing a slower growth in the ICU admissions. They are still growing. We still have a slight increase in mechanically ventilated patients in the last 24 hours, but the total number of cases in the system, which was almost 2,000 yesterday, seems to be holding at that same amount once we include the discharges. So I think I hope the trend continues heading into a plateau.
Well, you mentioned ventilators. We've heard a lot about the ventilator shortages all over the media, as you know. And in light of this crisis, have you changed your algorithm for deciding when to intubate and also when to extubate some patients?
The short answer to that is no. We've used the same criteria for intubation that we would on most patients, which is usually surrounding your work of breathing or an abnormality in your arterial blood gas. We are fortunate at this point to have enough more ventilators than we have ICU beds, and despite expanding other step-down floors into ICU beds, we've been able to use some of the operating room anesthesiology ventilators as well. So we haven't had a shortage yet, so we're still intubating people and mechanically ventilating them as we see appropriate. What we have prepared to do is, if we continue to surge, we have begun to split ventilators between patients as a trial. And so we've done that a few times to patients that had similar cardiovascular resistance as well as similar lung compliance as a test, and it worked well. So we are prepared to do that if need be.
Very good, Joe. I think you have a question.
Yeah, I do. Dr. Varghese, are you using the ARDSNet basically ARDSNet ventilatory protocol, or have you seen any benefit in some modified vent strategy based on how this disease of the lungs is evolving?
Thanks for the question. As we're so early into this, we are indeed following the ARDSNet protocol to protect the lungs, which, as most people know, involves a high PEEP strategy and minimizing the oxygenation, as well as having low tidal volume ventilation around 6 milliliters per kilogram. We've implemented that system-wide, and speaking to other hospitals in the New York area, the other academic hospitals have all rolled out the same. So we are using the similar ARDSNet protocol for all patients that are very deep in the throes of the disease process, and as they start to improve, their lung injury improves, we start to wake them up, we'll get them off the ARDSNet protocol and switch them over to pressure support ventilation in preparation for extubation.
Very good. Out of curiosity, are you guys using anything, since so much of this is in the news right now, are you using any antivirals? Are you using remdesivir? Are you using the hydroxychloroquine or anything else, passive antibody therapies, or I guess it's convalescent plasma? Are you doing anything like that?
We're not using antivirals. What we have been following is some guidelines from the Society for Critical Care Medicine, which is mostly level C evidence, which is consensus opinion, as well as looking at some short-term data and anecdotal experience, again, level C evidence coming out of China and Italy, where they looked at remdesivir and another medication called sarilumab, both not indicated. The remdesivir was used for Ebola, and we're trialing that out early on in the disease process. The drug was pulled off the market briefly just because of quantities and was only available for compassionate use, and now it's again available for us to trial in patients that the infectious disease team sees fit. So that call is made by the infectious disease team as they review patients. Every patient in our hospital gets hydroxychloroquine as long as there's not a contraindication, along with azithromycin. The other medication I mentioned was sarilumab, which is an immune modulator also created by a company in the New York area. So those are our mainstays. We have also started a convalescent plasma trial, antibody trial that Mount Sinai is leading. And we have enrolled a number of patients in that. I think I don't know what number we're at yet, but in patients early on in the disease, we're anecdotally seeing very good results with that.
Very good, thank you. John? John? Well, let me just ask.
There you go. I got the microphone there.
Okay.
Sorry, Joe. Dr. Varghese, yeah, I was going to say, can you describe for us the usual course, if there is a usual course, that you can generalize of patients that you've seen? And can you sort of categorize it a little according to age and sex and maybe even their overall health? Because we hear so much about pre-existing conditions.
Okay, so in the intensive care unit, we're seeing the sickest of the sickest patients. So there's different usual courses with this disease, as we're finding out. There's no real usual course because there's some patients that are completely asymptomatic, and then those that have a large inflammatory side response and cytokine release who get intubated and are mechanically ventilated in the ICU. So I'll focus on those patients that become very ill and require mechanical ventilation and what we have been seeing in those patients. Invariably throughout our units, once you've progressed to requiring mechanical ventilation and intubation, the minimum time on the ventilator in our experience at this point is at least 10 days. And it's 10 days with an induced coma, and most of that time you're under neuromuscular blockade, so you're paralyzed while we mechanically ventilate you with ARDSNet protocol, low tidal volume ventilation. After around 10th, 11th day, somewhere between 10 days and 14 days, I should say, we're starting to see the lung injury improve, and we're starting to come down on the ventilatory support and able to transition patients, wake them up and transition them to pressure support ventilation, and we begin extubating patients, and we are at that phase now. I must say the first week was pretty depressing, as all we were doing was admitting patients, intubating them, lining them up, and sedating and paralyzing them. And now that we're close to 2 weeks out, every day, even as I could speak, in the cardiac surgical ICUs, which we have 26 beds, we're extubating 2 to 3 patients a day.
That's
and
fantastic.
then once they're extubated, it's approximately, the ones that have been extubated remain in the ICU for 1 to 2 days, just to ensure that they're have adequately woken up from the sedatives that they were on, and that their oxygenation and the AA gradient is reasonable for them to move on to a step-down unit.
That sounds remarkably similar to what we're seeing here in our institution. And can I ask you just, you have about 2 minutes left on, can you, for the benefit of all of us listening, what important lessons have you guys learned there in New York that you believe might be helpful to our listening audience, especially those who maybe they haven't seen a surge yet of patients, but looks like maybe they're getting ready to? What lessons and advice would you have for people who are perhaps waiting for that onslaught to happen?
I think that's a 20-minute question, but I'll try to do it in 2 minutes. I think the main thing to think about is, one, how are you going to use the people that are not going to be busy? So a lot of the operating room staff needs to be repurposed, and where can you put them? The patients require a lot more care than the standard ICU patient, so you need larger teams. Think about tier models to managing units. If you're a smaller hospital, you definitely need to think about tier models sooner than later, where you have one intensivist managing groups of teams who are looking at the patients. Larger academic centers have a little bit more support in that realm. Think about creating teams, so proning teams, palliative care teams for these patients. We've a line team. And so dividing up the responsibilities into various teams allows us to provide same care across the hospital as we open up new intensive care units in various locations. Think about amalgamating services. So we amalgamated the cardiac surgery service, the thoracic surgery service, and the vascular surgery service patients all into one unit, because as surgeries went down, the census went down, and we were all able to move them all into one unit. Hence, those former units were turned into intensive care beds. And always try to stay ahead. So it's trying to stay ahead of the disease and the virus by opening up beds before you need them, and being prepared are some useful strategies that I can answer for you in 2 minutes.
Well, thank you very much for your time. I hope you stick around to the end, where we're going to have some generalized discussion and questions.
Yes.
And Joe, I think you You might want to pass it over to Praveen now.
Yes, John, and thank you. And I have to, first of all, apologize to everybody. And Dr. Varghese, I do hope you can stick around because I think you and Dr. Matthew are going to have some really good information to be able to share between each other. But I forgot to introduce everybody the way the team needed me to. So we've all met Dr. Varghese, and we got his, everybody knows who he is now. I'd like to bring up, if I could, Dr. Matthew. Dr. Matthew, if you'd be so kind as to just say hello so that people recognize your face when we get to you, and we can put your name down underneath you, and the guys over there know who you are.
Hi there, Jeffy Matthew, The Woodlands, Texas.
Perfect. Thank you so much, sir. And then I think we have Praveen. He's up in New York. Praveen, if you could say hello to the audience and also say where you're coming from today.
Hello, everybody. It's nice to see you all. I was glad to see Robin too. He's been so busy. I barely see him these days. Used to working with him in the OR. Now it's hi and hello in the corridor. He's just so busy out there. Hi, Robin.
Hi, Praveen.
Very good. And then we have Patrick. Patrick, if you could do the same.
Yes, Patrick O'Toole from the Woodlands, Texas, just outside of Houston, and happy to be involved with this.
Excellent. Thank you so much. And then John, of course, we sort of know you, but go ahead so they can put your lower thirds up.
Yeah, good seeing you guys. I hope everyone's doing well across the country. I think it's going to be an exciting webinar to hear from the rest of our presenters.
Very good. Okay, so Praveen, thanks, John, and thank you, everybody. I apologize. Thanks for forgiving me. Are you seeing a significant reduction in elective cardiac surgery? And is this easing now? Like, are you starting to see some cases getting scheduled, or is it worsening?
That's a long question. I'll just answer it in a couple of weeks of scheduling that we have. The 3 weeks before we started easing off on our cases 3 weeks ago, the chairman decided that we're going to be proactive in this. We're going to stop elective surgeries. We're going to do only emergent cases. That was week 3 weeks ago. And then the following week, we saw a surge of transplants. Believe it or not, there was a lot of liver transplants we were doing at that particular time, added with a few heart transplants. That was week 2. Week 3 was the same thing. We saw a surge in liver transplant cases. The usual TAVRs then started coming down. Electives were completely off the grid. Only emergent cases were we were involved in the ORs. ORs were pretty much shut down for elective cases. Week 4, we have completely stopped TAVR, though we have a case posted tomorrow, which I was told that was an emergent case. The livers have come down. The heart transplant, it comes in waves, as you all know, has come down. We do pediatric cases, which have had elective surgeries go on for the first 2 weeks. Now they have slowed down as well. So right now, we don't have any elective surgery scheduled. The ORs are beginning to, they are moving the ORs a little bit, and I think in a longer run, eventually we'll start having beds in the OR, dedicate 1 or 2 ORs for the future ICU beds or COVID beds, is what I was told.
Yeah, Praveen, let me ask you a question. In terms of ECMO, how much of ECMO have you seen with your COVID patients, and has your normal ECMO caseload dropped off? I know here in Florida, our normal ECMO caseload is very high, and they've seemingly vanished, making room for in case we get a surge of the COVID patients. How have you seen that there where you are?
Well, traditionally, we are not a very big ECMO center. We do about, I would say about 40 ECMOs, 40, 50 ECMOs a year. So it's very hard to say if the volume has come down. But right now, as of now, we do not have any other ECMO patients apart from one COVID patient that we put on Monday. It was a VV ECMO that we put in. But the regular ECMOs, we haven't seen any surge on the ECMO cases on non-COVID patients.
And what has your strategy been for managing your ECMO equipment and the staffing?
well, we were ahead of the curve, unlike most of you guys. So the way we strategized it in the first, I built it up saying that we had initial procurement phase initially the COVID virus hit. We weren't too sure what was going to happen. Everybody were talking about ventilators. There was a big talk about having a surge of ECMO patients. We'll have a lot of patients on ECMO. So traditionally, we have ECMOs that we put in with the CentriMags with a backup circuit. So we could, at a given time, put 7 to 8 patients on ECMO in our institute. Apart from that, we have the cardiology that has their own equipment, which is the CardioHealth. They have 2 units that we can use. Pediatric, we can salvage another 2 ECMO units, which are biomedicals, and they're procuring some more CardioHealth. So in phase 1, we were at the procurement phase. We doubled up our ECMO equipment. We rented out a lot of equipment. CentriMags were doubled up, and we arranged the CentriMags in such a way that now we can put anywhere between 12 to 14 patients, plus an additional 4 if we have to. Meaning CentriMag needs a backup. So we could probably use 4 or 5 patients, have a backup equipment outside. So we are geared up for that. More than the equipment, renting out the equipment, we saw it was very hard to find oxygenators. McKay has come down with their product delivery. So we had to look for alternatives. We managed to procure some other companies. We got some from Medtronic. We got some from AMP, which is the newest oxygenator. So at this particular time, we are geared up for at least 10 or 15 cases for sure. We could probably procure more. And also, I mean, if we think from a perfusion standpoint, push comes to shove, we can always manipulate pumps that are inside the ORs to maneuver to become ECMO circuits if needed. But we haven't seen that surge yet. The next couple of weeks, we don't know, but we are we're in a very much prepared state.
Thank you so much. I think Joe has a couple of questions for you, Joe.
Praveen, and that is, are your operating rooms being repurposed for ICU bed space? I think you said that you're getting them ready for it, but my question maybe more specifically is, do you actually have anyone in the operating room that was an ICU patient? Have you had to use any of those rooms?
No, like I said earlier, we have not gotten to a point where the operating rooms are being converted into ICU. But I'll tell you something more interesting. All around the hospital, we have a very big foyer. We had a cafeteria like a Starbucks out there. They have tremendously worked on that. I think in a week or 2, they have made ICU, or Robin, correct me if I'm wrong, but it's so well done with almost, I think we have 14 or 15 beds that are being converted. Every ICU that we have been converted. We haven't still percolated into the operating rooms yet. I mean, we have seen an increase in the caseload. As of today, I was looking at the daily bulletin that's sent to us. We have almost 2,000 patients in the hospital. 450 are in the ICU. Another 195 being tested. So another next couple of weeks, we might fall short of beds, and that's when I think they might think about opening the operating rooms.
I think, if I can make one comment on that, we're actually trialing out putting 2 patients in one room in the intensive care units. And so we have trialed that out in 2 beds in every ICU, just so we can see what the issues are that we have to work through. And it seems to be working well. And so we now have 300 beds that can become 600 beds. So I think we're probably not going to head to the operating room, although, as Praveen said, that was our original strategy to consider that as an option. But the 2 patients in one room seems to be functioning reasonably well, and we'll be prepared to do that if need be.
That's very interesting. Praveen, let me ask you this, and maybe Dr. Varghese, you can also talk about it, and then later we can address it again with the other folks. But what about cross-discipline coordination? You talked about all the various different teams that you have, but not just cross-discipline coordination in your hospital, but across the system in managing these patients, distributing equipment, distributing personnel, moving patients, sending patients to place A or place B preferentially. What's your experience with that, Praveen, in terms of everybody working together in a coordinated fashion?
Well, the last couple of weeks, Joe, I can tell you something that we have learned to work as a team, and cross-discipline, cross-education. I call this a cross-education because every particular day we're going out. Our anesthesia team has been excellent. A lot of the stuff that we are doing that we are normally not used to, like donning and doffing, is something that we, as a perfusionist, we never did that. So they have been organizing sessions, classes. They are available 24/7. If you have any questions, you reach out to them. The intensive care has been exceptionally good. We go out there, we learn we have started to learn about ventilators. I know a lot of people who are in perfusion are well versed with ventilators because they come from a respiratory therapy background. Now, some of us aren't, so we are starting to learn a lot about ventilators and how we can help. We have been training. We have been, ourselves trying to go out there and train nurses, whoever is interested in learning anything about ECMO, trying to make ourselves available. But not only that, I think in this particular instance, when we have an intensivist, Dr. Varghese out there, they have been constantly in touch with us, telling us what we reach out to them. They send out bulletins to tell us what is going on and what is the new equipment that they might need, or they might need a certain help. That we've been constantly in contact with it. The leadership has been exceptionally good, and we have been kept in the loop, always prepared. Training is what I would suggest for most of the institutes, because remember, a perfusionist can only do certain things, but I think this is the chance to increase the scope of your practice, learn many things, and there are so many advanced things. Like I was talking to one of the anesthesiologists who was giving us a lecture, and they are experimenting on converting. I mean, in fact, there was an article today, that was what I was discussing about. They have converted the CPAP, BiPAP machines, they're converting into ventilators, and I was picking his brain as to understand how they're doing that. So there's a lot of cross-disciplinary education and training that's going on, and from weeks to come, we don't know how it's going to be useful at this point.
Very good, thank you. John, do you want to take this last question here?
Yeah, Praveen, that's exactly right. We're having to be very creative. This, if there is a silver lining, this has all stimulated us to become very much more creative and inventive with the things that we do have. And like Dr. Varghese was just saying, you guys are looking at putting 2 patients in one room. I don't even think that's even been discussed, that I've heard anyway at our institution. But let me ask you, I don't know if you have done an actual cabbage or valve patient that was or is a COVID patient. If you have or if you have not, what thoughts and considerations have you given to doing an actual COVID patient that would be on a regular open heart procedure, for the benefit of our audience and people who may not have faced that?
That's a very good question, John, because we were thinking about it. Most of us are, on an emergency basis, if we were to be called for a dissection or anything, 90% of the time, I don't think so they would even get the result of the COVID virus. So we have been very proactive in how we're going to treat any patient that's going to be elective coming into the OR is going to be treated as a COVID positive patient. If we have the results done, well and good. If we're not, then we're well prepared. Meaning we're going to follow all the practices of donning and doffing. We are going to protect our staff as much as we're going to protect the patient. And we have decided we're going to use the equipment the way the cleaning of the equipment post surgery, utilization of 2-man perfusion, one being outside the room, vigilant, asking for help. Because in our institute, we just do 1-man perfusion, and we have a person available. But in this situation, we have decided to have two-man perfusion, one standing outside the room just in case something is needed. The other person is going to completely dress, have the proper PPE technique done, double up everything if needed. Not that we are going to be, it's not a blood transmitted kind of a virus, but we are going to take all kinds of precautions. But answering your question, we haven't seen any of those patients, COVID patients that we operated on. But there was a scare. We also procure hearts for our heart transplant surgeries. And one of the hospitals we went to, they weren't too sure if it was a COVID positive or not. We took all precautions, all necessary precautions of PPE techniques and donning and doffing. And when we were bringing the heart out of the OR, that's when they told us it was negative. So yes, from now onwards, I think the paradigm of surgery, the way of thinking for the next couple of weeks is going to change. Everything is going to be treated as a COVID positive patient, and that's how we're going to treat every patient going to the OR, even if it's an elective case.
That makes a lot of sense.
Well, that's fascinating, and we're up against the time, but I just wanted to comment. That throws a very interesting point into this, and that is our operating rooms are positive, are air positive, and what you're talking about, having a perfusionist as a runner in the hallway, and you or the other one donned inside the OR, but you're still passing things through the door, which it's a positive pressure room, so you have an escape of the of possibility of the virus going into the hallway of the OR. I know Joe has some questions for Dr. Matthew coming up, but thank you guys so much for that. We appreciate it.
Thanks a lot.
Thank you, John. Yes, hopefully they'll stay around, because I'm writing down questions as this is all going on during the Q&A section. Dr. Matthew, let's move on to you, if we could, please, sir. And in deference to being respectful of privacy and so forth, perhaps you could just describe the patient's demographics, how the patient presented to you at your hospital, and what you saw from the time that you got the patient on your service until the time that you made the decision that you needed to escalate his care.
Sure. Yeah, thank you, Joe. Yeah, let me just start by saying, we're a small community hospital about 30 minutes north of Houston, Texas, in a suburb called the Woodlands, and it's a small hospital, but incredibly talented staff, and I have had the privilege and the honor of being the director of the medical intensive care unit there at that hospital. We've got a great team, a closed ICU with intensivists, nurse practitioners, physician's assistants, and a great hospitalist service as well. So this gentleman, you could not come up with a more poster child type presentation. It met all the classic criteria that we hear. That's been publicized, that's been talked about. Just you ticked off every one of the boxes. Previously healthy gentleman with no past medical history, and interestingly, no travel history, in his early 40s, and he came in with about a week's worth of upper respiratory tract infection symptoms: cough, congestion, shortness of breath, low-grade fever. And he has had the flu before. He thought he perhaps might have the flu once again, or some type of viral syndrome. Continued to progress, and so he sought treatment in urgent care and was given a typical Z-Pack and Medrol dose pack, and again failed to improve from that. And a couple days later presented to our institution, and that was in the beginning of March. And so this was, for us in the Texas area, we've had a little bit of the benefit of being behind the curve and seeing what was going on elsewhere. So COVID was obviously very high up on the list, and that test was sent. Initially, again, just like you would expect, he had typical upper respiratory tract, lower respiratory tract symptoms. CT chest was performed, and he had very classic findings there that we can discuss and talk about. But his presentation, again, like I said, could not have been more classic. Initially, he looked very, very good. Mild oxygen requirement. He looked good. Again, COVID was a strong risk, and so he was admitted to a medical surgical floor, where we had, at that point in time, had not started cohorting patients. But under all the proper precautions, and ultimately his test did return positive about 2.5 days later.
Mm-hmm. Thank you. John, you have some questions?
Yeah, Dr. Matthew, I have a question. Do you feel that your team was adequately prepared, for your first COVID patient? I don't mean that in a negative way. I mean that in a positive way. And for the benefit of our listeners, what additional preparations might you recommend to those listening before they get their COVID patients? And I know when we received ours, we thought we were prepared, and we found out that we were probably maybe 70 or 75% prepared for it actually when it actually came, because it was very cumbersome, the multiple layers of PPE and the whole process of donning and doffing and not trying to contaminate the hallway of the OR and whatnot versus the room. So I wonder if you could comment on your preparations and what you think that others might look for.
Again, sure, great question. And I think for centers who have had the benefit of being a little bit late and behind the curve, I think we were extremely well prepared. I'll tell you, this has been an incredible time in medicine to be practicing, where the degree of collaboration and communication, I think, both time and technology has helped. I've had the privilege of being part of various chat groups, and actually did interact a week or two before with colleagues in the New York area at Mount Sinai, Bellevue, learning from their experiences. And again, I think our preparations have been in anticipation of this surge that has yet to come, luckily, for this area. So for these patients that have been trickling in to our hospital, I think we've been incredibly well prepared. We were able to learn from the experiences of centers both on the West Coast and the East Coast who've been dealing with these patients. We were able to follow proper procedures in terms of PPE and get the necessary supplies available for the staff. It's been, both a kind of a dual process and goal in mind, and that's to adequately treat these patients with the resources that we have available. And so far, we're likely to be well stocked in terms of resources, to treat them appropriately and properly based on a very challenging, almost every 2-day changing paradigm and regimen of what the appropriate treatment plan should be. But also, the second part is, how do we also maintain complete protection for our healthcare staff? And that's been also paramount. And I'd say both of those things have been, equally important to us, and I think we've been able to navigate that. I will say, the fact that we've had patients trickling in has allowed us to be able to do that successfully. And I think that anticipation for this tidal wave had gotten us revved up and, acting on kind of a, fourth, fifth gear to get prepared and to be ready. With this gentleman's case, I can't, looking back in retrospect, I can't see anything that could have been done differently. We were very lucky to have had a good set of the team with had it on their forefront of their minds, and so he was considered a PUI from the get-go. So appropriate precautions were taken, and we were able to kind of act as the situation progressed.
Yeah, I think you make an excellent point. We've never been more separated, but yet we've never
Right.
been more in touch with each other at this time. Interesting time to, in fact, the information is almost information overload on a daily and hourly basis. And
Yeah.
it's almost hard to digest all of it. Could I change gears just a little bit and ask you, when you did get that first patient, did you, in terms of visualizing the chest X-ray, was it something that you expected to see in that initial chest X-ray, or was it at all consistent with what you were reading and hearing about that you would see on the chest X-ray?
Yeah, the CT findings could not be more consistent with what's being described in the literature and other centers. Again, classic bilateral ground glass opacification. Again, peripheral distribution in a patient, with otherwise no predilection for that. Again, you wouldn't think of it if you came across this last year, you would have thought about the standard differential diagnosis or an atypical pneumonia or a viral pneumonia. But given, again, the fact that we were a little bit behind the curve, we were able to say, okay, this CT in and of itself is quite diagnostic for COVID, and that was even in 2 days prior to the test coming back.
Thank you so much, Joe. I think you have a couple questions for Dr. Matthew.
I do. So Doc, ultimately this patient did go on ECMO, and I can certainly understand the evolution of, we're going up higher and higher on the vent, saturation's going down. Perhaps you could maybe express a little bit where those vent settings were going, where they may have actually gotten to, and then did you have any direct concerns about the decision to use extracorporeal oxygenation or use ECMO VV on this patient?
So, thanks, Joe. So here's, this is a place where I think now in retrospect, perhaps we are operating a little differently. At that point in time in early March, we were still following a lot of guidelines, particularly from our colleagues in Italy, who were recommending, and China, who were recommending very early intubation, as opposed to kind of traditionally taking a look not just at the numbers, not just at the oxygen saturation, but the patient in total. At that point in time, I can say we were following the recommendations of our colleagues who were saying, don't wait, intubate as quickly and as early as possible. There was a very rapid progression. The gentleman went, ECMO was not on the table at all 12 hours earlier. It was that quick of a turnaround where we were seeing, again, a patient who was walking, talking, looked pretty good, progressively more tachypnic, but still there with us, and a tremendously rapidly increasing oxygen requirement. His actual time on the ventilator was not that long prior to the decision to initiate ECMO. And again, I think, with in hindsight, in retrospect, and now some changing recommendations, perhaps a similar patient that walks in, we have a different paradigm in place where we're allowing for a little bit more time, not rushing to intubation, utilizing awake proning, proning of the intubated patient, watching fluid balance a little bit more cautiously and closely, and again, some of these medication regimens that you've described above as well. Those were things that we did not entertain early on as we were taking advice from what the collective experience had been up until that point. So the decision to go from rapidly increasing nasal cannula to full oxygen support, eventually mechanical intubation, and then within 12 hours ECMO, was done kind of in that context, based on oxygen saturations that went within the 4 hours from 95% down to the 60-70% range.
Wow, that's incredible. Now you also used remdesivir. Was that compassionate use, number one, and or was it just off-label? I'm not sure. I'm not that familiar with remdesivir. And can you tell me if you saw any significant change in the patient when you started that drug protocol?
Well, as you know, in the ICU and an intensive care patient is critically ill who's receiving multiple interventions, it's very difficult to attribute any type of change to a single variable. We did use remdesivir. We were able to apply for and receive compassionate use authorization from Gilead, so he did complete a 10-day course of that. It was in that same 10-day course that he was on ECMO and receiving maximum support from all of our colleagues, both critical care, infectious disease, and otherwise. He did slowly and steadily improve. I would hope that a little bit of everything we were doing was making that difference. There was a very steady progression and gradual improvement in his P/F ratio, just in terms of his general vital signs and presentation and radiographic improvement. It was all slow but steady. And again, hopefully the remdesivir had played a part in that. That's not something I could state for certain, but we are very glad that we did have that ability to get that compassionate use indication, which I know is not necessarily available now, but he was able to get that.
Very good. John, you want to wrap this up?
Yeah, Dr. Matthew, that sounds like a fascinating first case. And could you just summarize how the patient is doing now today?
He's doing phenomenally well, better than I think any of us expected in terms of the speed of his recovery. After about a 14, 15-day course, again, typical 2-week or a little over 2-week course on the ventilator and ECMO. He was weaned. He's been moved at the beginning of the week to our inpatient acute rehab unit, where he's aggressively functioning with PT and OT and starting to ambulate. He's in good spirits. tremendous amount of paralytic and sedatives required, as you know, and I think we were all expecting kind of a delayed improvement from a mental status standpoint, but he has really just been exceeding expectations and doing quite well.
That's fantastic. Fantastic.
Yeah, thank you very much. That was a fascinating presentation, and I hope you stick around a little bit later for our closing questions and comments. And I want to bring in now Patrick O'Toole. He is the perfusionist at St. Luke's Medical Center, the Woodlands. And Patrick, when you were originally called about this case, did you feel you were prepared in regard to the equipment that you needed, and as well as your mental preparation? Do you feel that you were adequately prepared? I'd like to hear your comments on that.
Well, sure. Equipment-wise, we're always ready to put somebody on ECMO, at the hospitals that we cover. So I wasn't worried about anything, of that sort. But, we had a conference call, our group, our perfusion group, and talked about what was coming and to get ready and to, there was going to be no more vacation. There was going to be no more, weekends off or anything like that, that we were all going to be ready to do this. And the call came sooner than I thought. So, the next day it was when it happened. And, driving in, I would say my thoughts were, what gave me comfort is, we're first responders, and it's important that we, consider that first before anything else. And so there was just sort of a job to do, and I was going to go in to do it. But I was concerned about, PPE and were we going to have everything that we needed, because there was already people talking about not enough of that equipment being around. And I was the first one to go in and handle this sort of a patient.
Joe, I think you have a question or two for Patrick?
Yes, thank you. Patrick, could you please describe for our audience, since you had to don a whole big thing and there had to be somebody there to teach you to do this, which has been discussed that maybe we should have been trained how to do this sooner, but nevertheless, would you describe for our audience what protective measures you had to take in order to protect yourself from a potential exposure?
Well, I have to tell you, when I got there, the first thing I always do is, if we're going to put an ECMO in, is I like to go just get our equipment from the operating room and go ahead and prime that up and do that in the piece of doing it by myself. I'd rather not do that in front of a bunch of people if they're waiting for us to go on, So I got everything primed up and went up to where we were going to do this bedside. And I was really pleasantly surprised. I mean, there was an infection control person there to show us how to put the PAPRs on, and clearly described what was going to happen when we left the room and how she would be there to take us through each step on how to take the equipment off safely. And I felt very safe doing what we did. It was really a good experience.
Excellent. In regards to the ECMO circuit, what was the cannulation strategy in this case, and did you do anything different from a standard VV ECMO that we would do for any other thing, aspiration, influenza, or just ARDS for any reason? Did you do anything different?
Well, we normally, for a veno-venous ECMO, we're using the Avalon, and it's a dual lumen cannula where we have inlets coming from the IVC and the SVC to the oxygenator and then back into the right atrium. And so we use that same sort of cannulation. And I wouldn't say we did anything different for this patient, because most of our patients that we put on veno-venous ECMO are ARDS. It's just that this one happened to be due to the COVID-19.
Mm-hmm. Very good, thank you.
Yeah, Patrick, there's been a lot of talk about once you got the patient to the ICU, monitoring the patient. Some people have tried to put the ECMO unit outside into the hallway, and certainly people have tried to face it towards the window. What changes or anything have you made in terms of monitoring the patient effectively and keeping in mind the conservation of your PPE?
Yeah, I think the conservation of PPE was definitely on my mind, and we spent quite a bit of time in the room making sure that people outside of the room could see all of our equipment and that we could see the venous line if there was going to be any chatter, and we would know, what to do there. An interesting story is that, by the time we had this patient on ECMO, our clinical manager was there, and she put a note up. I was about to come out of the room, and she put a note up on the window, and it said, "They want you to stay in for the entire shift," which was another 8 hours. And I thought to myself, I don't know if that's even going to be possible. I mean, you can't use the washroom, you can't have your phone or anything in there. So the first thing I says, let me just go out and use the bathroom if I'm going to stay in this room for the whole time. So I came out, and luckily that idea was changed. And what we came up with was that the nurse who was covering the case would go in to handle their pumps, their IV pumps, every couple of hours, and that the perfusionist would tell them, if there was some small adjustments to make, that they could go ahead and do that while they were in the room. And also, if there was going to be something, if we were going to be adding, albumin or something to the circuit, if there was, venous line chatter or something like that, we would go ahead and go in and do that, but at a minimum. So the nurse was really able to make those changes by going into the room when they did on a regular basis. I will mention, though, that we didn't do it with this patient, but going forward, what's been a really good idea is that they've moved their IV pumps outside of the room and just ran longer lines, which is just a great idea because that minimizes the number of people in the room.
Mm-hmm.
Well, that's sort of what I was getting at, because there's places that are trying to figure out a way to run the IV lines under the door, and even perfusion lines and even CRT lines under the door, and try to essentially manage the patient from the hallway. And I know that there's some places that have an ante-room in their ICUs, and some places do not, which poses a different type of a challenge. And what would your comments be, though? What could you summarize and say in terms of the communication coordination across from the room to the outside of the hallway, but also from discipline to discipline? And then what was it like to wean and even come take the patient off of ECMO in that environment?
Well, I think that clinically we had very good communication between pulmonology and respiratory and perfusion and nursing and everybody else involved. I think that administratively there were probably some misunderstandings, but this was the first time we'd ever handled a patient like this, so that shouldn't be unexpected. I guess for an example of that, it would be that first off, I thought that the decision that somebody as a perfusionist would be in the room the entire time, 24 hours a day, with PPE on was, something that probably wasn't completely thought out, but we were able to get that decision changed, which was helpful. Secondarily, when you come into the hospital for your shift, if you're going to be covering ECMO or whatever you're going to be doing there, they take your temperature and they're screening you and they ask you a few questions. And one of them is, have you been in contact with a COVID-19 patient? And so, all of our answers who are treating these patients would have to be, yes, we have. And, does that mean I can't go to work that day, or what does that mean? So I think there was some confusion on that. And then the decision was made that we would be able to go and treat only this patient at this one hospital, but we wouldn't be able, the perfusionists that had been in the room wouldn't be able to go and do cases at any other of our hospitals, which put a big stress on all of our staff. And that decision was later reversed, but I think there was a little bit of a learning curve on how to deal with something like this. We never have before, other than H1N1.
Yeah, that's a very good point. That's sort of what I was saying earlier about how rapidly how fluid the situation is. and how the information and the recommendations, it almost can change day to day. You may find yourself working at one hospital, and that other hospital doesn't, in your neighboring hospital that you also cover, doesn't want you bringing those germs into their hospital or carrying something into their hospital. So this has posed an amazing number of challenges and questions that we never had really before. And I know I thank you for your comments there, Patrick. And I want to hand it over to Joe. He wants to bring in, I think, Dr. Samir now.
Yes, Dr. Samir. Hello, sir. How are you today?
How are you, sir?
Good.
Sorry for the technical difficulties.
Say that again?
Sorry for the technical difficulties.
That's okay. You might need to speak up just a little bit or move your microphone closer to you so we can hear you. But it's nice to see you. You look fantastic. Look, you're a cardiac transplant anesthesiologist and intensivist in the Texas Medical Center. You're a telemedicine expert. And you're certainly recognized, I think, as an expert in the field of tele-ICU. What are your views on how this pandemic will continue to evolve? What do you see?
Currently, can I make a couple of comments about the ECMO monitoring?
Sure.
I didn't know I wanted to interrupt before. See, EICU plays a big role right now, where you can monitor the ECMO from outside the room. You have the cameras in the room, and you can see what's going on, and you only have to get in the room if you need to intervene. So if you put your IV pumps outside the room, and then you really minimize in and out, and and the exposure. So that has been used successfully in the medical center, where EICU is watching, and it will alert the outside team if there's any problem. And keeping the pumps outside is a great idea too. So really minimizing the donning and doffing, and with all the exposure to healthcare workers has been. So that's one thing. So I do think now, what I think is going to happen right now with the epidemic, I think as long as we're doing our distancing and doing what we need to do, I think things will kind of flatten out. Firstly, one thing I want to say, because I know there's a couple of guys from New York, my hat's off to them. These guys are amazing and do an amazing job being in the front line. Well, what they're going through, nobody else is going through. And we definitely need to learn from them and not try to be in that situation. So, I use New York as the extreme. And I get in touch with my friends in New York every day, and I learn from them what to do and what not to do. So I'll tell you what, hopefully this epidemic will flatten out as long as we social distancing. And we're getting all anxious. Easter is here. People want to go to church. Well, I don't want to be any religious. I think people need to stay home and stay distant from each other.
Very good. I agree with you, and I agree with you about the folks from New York. They certainly are. They are bearing the brunt of this. I mean, their hospitalization rate and their ventilatory rate and their mortality rate is frightening. And I'm glad I'm not going through it, but I do feel bad that they are also. Let me ask you a question, if I can. Do you think, kind of like the way Dr. Matthew was talking about early intubation, don't wait, the information that was gleaned from China and the other early places. Do you feel that same way about ECMO? Do you think we should be putting patients on ECMO sooner, especially if they're younger and viable and seem to be having a real cytokine storm right in front of you?
My thoughts, Joe, always, if you're thinking about ECMO, do it. If you have a thought about doing ECMO, put it in. Any delay is not a good idea, because if you're getting to the point that you're thinking about it, then it's time to initiate the team and get it doing. You do not want to do it as an emergency. You want to be like a regular case, when everybody's ready, no rushing in the room, no rushing to cannulate. You're not cannulating while you're doing CPR, you're not doing anything like that. You need to, if you think about it, get it going. And get it going early. Get the team together, and you want to be safe for the patient and for yourself.
Mm-hmm. Very good. John?
Dr. Samir, good to see you again, sir. It's been too long. We have to get together again. But I wanted to shift gears a little bit and ask you, what are your thoughts about, chloroquine, hydroxychloroquine, remdesivir, antiviral, and also the passive antibody transfer treatments? What are your thoughts about those?
Okay, I'll tell you. I mean, I cover a smaller hospital, and that hospital, if I get a COVID-19 patient that I decided to intubate, the patient is starting on Plaquenil and Z-Pak right away. I don't hesitate. I talk to the patient and the family about the risk and benefit. If the patient is willing, I go ahead and start right away. Methodist one of the study places for remdesivir, and I'm a big advocate for remdesivir as an antiviral. I think it should work. Is it proven? Not yet. Antibody transfusion, one of the most smart people I work with is heading the study at Methodist, and he's doing an amazing job. Are the patients reversing course? They are reversing course. They're getting extubated earlier. But this is anecdotal. The numbers are not big enough. But the question is, if you're the patient, do you want to deal with anecdotal or you want to get the treatment right away? I'll tell you about myself. I'll take whatever risk it is, as long as maybe it works. It might not work, but maybe it will work. And I have to tell you something, and I'll be a little controversial. I'm not worried about the QT issues with the other drugs. Not worried about the QT. I mean, I'd rather get shocked once than and recover quickly. So, I mean, I think you inform the patient and the family, you can go ahead. And really, I talk to the patients sometimes before intubations. Those patients, I know they cannot breathe as well. They're going to get intubated. They know that they're in a very bad situation. If the patient says, okay, remdesivir on the study, get compassionate care, you can get the dose. So I'll tell you, I'm a big advocate, start early, do not wait. There might be a benefit, but the risk I feel is very minimal compared to the benefit.
Yeah, that's interesting. You know, I speak with centers all over the country, and you really get a different response and a different algorithm and approach to these drugs from just about everyone you speak with. And most are probably not going with remdesivir very much, and from what I'm hearing. But like you said, there's some merit to it, I suppose. Let me shift gears a little bit and ask you, you know, I've known you for a long time, and you've been an early pioneer of an advocate of telemedicine, the telehealth system. And, you know, we're hearing so much about that now on the news and on the media. And where do you think this technology is heading? And especially in light of this new, epidemic that we've seen and this new crisis that we've seen, I would think this is going to be a real boom for the telemedicine process. What are your thoughts about that?
It's been amazing, to be honest with you. And I commend HHS for removing the barriers. I mean, I was very impressed how HHS has removed the barriers for telemedicine across states, which has helped a lot. You have to remember now in the state of Texas, you cannot get tested unless you get pre-qualified by a telemedicine doc, and then you get approved to be tested. So I think right now for the access for the patients and for the safety of the providers, telemedicine really is taking place. And telemedicine, tele-ICU, across the board. Right now, I'll tell you, you know, John, I mean, I have my desk right now has different laptops from different hospitals that I'm covering. The demand is unbelievable. And I'm trying to help as much as I can because I'm protected from my desk, covering many hospitals while these guys going in and out, and I feel bad for them. Actually, I feel guilty that I'm sitting at my desk and just trying to help them as much as I can. You know, help them take care of the patients, provide them with data when they have to go into the room and intervene. And I really feel that telemedicine is going to be the backbone of the healthcare right now. And the front line will always be there. We're going to be like the AI, providing the backbone for healthcare, putting the docs on the front, tell them you need to go in and intervene right now. And you don't have to go in and out and intervene and expose themselves. And again, I'm really concerned about, I mean, and even New York, the big push for telemedicine, like a crazy push. Same thing with New Jersey. I was surprised that Northeast is pioneering telemedicine. I mean, Texas has always been with telemedicine, but now the Northeast, which is very litigious, has now been pushing telemedicine very high. And the request for tele-ICU services has been like unbelievable. And now we were talking, me and Joe, in the past about tele-ECMO, and now that's going to be like mainstream now. We're talking about something pioneering. It's going to be mainstream. Well, you can, instead of having a perfusionist like Patrick was saying today, sitting there he has to go to the bathroom. I mean, he cannot just be stuck in a room the whole time. And that it's not real even. And if he got stuck in the room, how is he going to cover another hospital and go from one hospital to another and come back and forth with the infection control issues, which is a big issue. So the tele-ICU is to take care of patients and provide us with safe care. That's what I feel.
Well, Dr. Samir, you answered all of my questions. So, John, do you want to go ahead and ask him about the CRRT? John? Did we lose John? Okay, I'll ask him. Dr. Samir, what are your thoughts on these patients getting early CRRT, CVVH, or molecular adsorption therapy for the removal of the inflammatory mediators?
I mean, I'll tell you, and I know, Joe, if I was next to you, you'd hit me probably. So I'm glad that I'm far by, by Skype. I'll tell you, you and I know one patient together that did not get CRT and did very well. Okay? And well, I think you should start it early if you need it, but I don't think you should start it empirically.
Mm-hmm. Yeah, I can't say I agree with you, but that's okay. That's okay. We disagree about that all the time.
Well, now I know the same patient that did very well, and now is sitting up in bed, eating his eggs, ham, and cheese, and doing very well. And I appreciate. Well, I mean, so you have to look at that also. The results in front of us.
Yes, that's true, but it could have been sooner, so we could have that discussion too. So let me ask you this: what about these novel oxygen-carrying nano molecules like what this company Bioxytran has, BXT25? Do you see a place for something like this? In patients. In other words, I see so many experimental things being done, for compassionate care. And of course, something like a nanoparticle that is oxygen carrying that can move through, these spaces in the lungs and pick up oxygen and deliver it to the tissue more easily than, let's just say, a red blood cell can. It seemed to make sense. But what are your thoughts on it?
I mean, again, this is all technology that was in front of the FDA, was taking delayed approval, and now all this happening is being pushed to the forefront. My thoughts are: you explain to the family, you explain to the patient. If they're gonna go for it under compassionate care, I would try it. If there's no drawback, I would go for it. What is the bad thing that's gonna happen? If it doesn't work, well, it's not working anyway. The patient's on ECMO. So I think you're obligated as a healthcare provider to do everything you can to save life.
Mm-hmm. Yeah, I think.
I say that because, again, Joe, we're in Texas, and we have limited liability in Texas. You know that.
Yes.
But you know how far we push with LVADs and ECMO. We definitely broke boundaries. But I have to say, with that said, I mean, I'm more aggressive in starting new therapy, novel therapy, because I know that we are protected. And now, you have to fully disclose to the patient the risk and benefit, and make an informed decision. I mean, and I always say it might not benefit, but it might not hurt, but it might benefit. The question is, what's the harm? If there's something with a harm, then I would not start it. But if it might benefit, but we're not sure, then I would go for it. If this was you, give you that choice, I'm almost sure that you're going to go for it.
I would agree with that. So, Dr. Varghese, if I may bring you back in and ask you to please take the last few minutes to give us all some sense of what it is like to just be in New York at this time as a healthcare provider, and how, based on your experience, extensive experience thus far, our audience can prepare for what could be a surge of this or something else that happens at another time. What do you want people to take away from all of this in your experience?
Thanks, Joe. I think we talked a little bit about that earlier, but just to summarize, I think the key salient points are here is repurposing the staff that you think are going to be free and available to help, which would be staff from the operating room, staff from clinics that could come and help, and find what they're experts at and use them in those areas. So anesthesiologists may be a great line service team along with interventional radiologists. OR techs became our proning team. We trained them and they learned to prone. Prepare education would be the second thing I would say in advance to start training people and training people that are not used to taking care of critically ill patients on how to manage the ventilator. So we created 4 modules that were 30 minutes long. People could sign up for these sessions and with a simulation, and we rolled that out about 3 times a week and had intensive care critical care faculty educate people who'd sign up for this. And so education is very important. We created a Dropbox, a COVID Dropbox that anybody could go to, where we put in most of the policies and protocols that we were creating on a daily basis. As a policy came through, we put it in the COVID Dropbox. As a new paper came out, we put it in the COVID Dropbox. So we had an avenue using new technology to allow people to access training modules. And then the third thing I would say is just-in-time training. And so we took people who never worked in an ICU and said, you're going to be working in the ICU starting tomorrow. You are an operating room PA, but we're going to train you. And so they stood next to a buddy who was a critical care and PA, and that person would train them the first day. The next day, they would start putting the orders in with the critical care PA following them. And so a lot of just-in-time training we found has been effective, using people to the skills that they have. I think having a lot of encouragement and support is also important this time, and so disseminating information is important so everybody feels like they're in the loop. As Praveen had mentioned, we get a couple updates a day from the system about how many patients are admitted, how many patients are in the emergency room, how many patients are mechanically ventilated, how many are intensive care units, to give everybody a sense of where we are as a hospital. And then I think it's important, now that we have some understanding of the disease, to encourage the staff that first week to 10 days are going to be tough, because you're just going to see the ICUs filling up and very little improvement in patients. But the successes come after that 10 to 14 days, and people start getting extubated, they start waking up, and you're starting to see them as people, and these people with families. One thing we made sure we did was every patient got a phone call to the family by the medical team, not just the nurses, but by an MD or a PA would call the family and update them in detail as to how their family was doing, because these family members who normally would love to be at the bedside are not allowed to visit them in the hospital. And so we felt that was important to update them on a regular basis, in addition to the phone calls that they would have with the nursing staff. And finally, I'd say stay ahead of the virus. So as you start filling up one ICU, have the plan for the next one ready to go. As you start moving into that one, have the next one ready. So be prepared for where you're going to move patients. Start the construction process to get negative pressure rooms organized, putting doors on ICU rooms. Whatever's needed, try to stay ahead of the virus, because the onslaught can come, and it can come quickly.
Very
I hope
good.
that helps.
That was excellent. Really, I appreciate it so very much. Praveen, how about your closing thoughts, sir?
Well, I think that was great views from all of you guys, but I think this is more from a Perfusion standpoint, and I was listening to what Patrick was saying. I think it's very important as a group, as a Perfusion team, you have a team A, team B as your backup plan. I think that would really help a lot. Secondary to that would be simulation labs. I think a lot of the ECMOs are not coming out yet, but you will be involved in a lot of ECMOs coming in. Simulation labs for your staff, and how to don and off on a regular basis, because once you see, it's easier seeing, but when you really do it, it's hard to communicate with your, have a team ready, do some wet labs, try and extend, try and be creative as how you're going to extend the lines. We had a few thought processes. We had one ECMO, so we ran a few scenarios, and at the end of the day, I think it's easier to run the ECMO from outside the room, and there are multiple centers that do that. Columbia is a bigger center. They've been always doing. They just have perfusionists round up their 20, 30 ECMOs they have. You can start following that thought process. You don't really have to be sitting next to the ECMO 24/7 in order it's a VV ECMO for most part, and these are pretty stellar. You don't need to intervene with them on a regular basis. The nurse is already there drawing blood gases. If that's what you minimize your exposure to that, and plan ahead. I mean, at the end of the day, it's how you plan and assign your team, who's going to be on call and who's going to go in, who's going to be this. You require 2 people to initiate this ECMO. One has to be protected, one has to be inside the room, the other one has to have a plan and get things done. The other thing that really helped us out a lot was having everything in a plastic bag. We have all our ECMOs set up with all the cannulas, plastic bag, the masks and everything. And when we get called for an ECMO, it's like a team. We just pick up that bag with the ECMO cart and we run. Everybody's aware of what is in there, depending on what your staff, the size of the mask, that kind of cannulas. Usually it's very, very simple. The cannulas, they're probably going to be 17, 19, 25, depending on what the veno kind of cannulation your surgeon preferences. There's only very little cannulas you have out there, but the cart is always outside and there's a perfusionist ready to. I think more preparation is what is important, and I think wet labs will keep you ahead of the curve.
Very good, Praveen. Thank you so much. John, do you want to?
Yeah, thank you for that, Dr. Varghese and Praveen. And I wanted to bring in Dr. Matthew and Patrick back and kind of run that same question by you. In your guys' experience, what could you summarize and leave with our audience for recommendations and something that they can, take away in preparations, and also for some strategies that you've learned that surprised you a little bit for the benefit of our listening audience. Dr. Matthew first, please.
Well, I'll tell you, this might not be kind of exactly the medical treatment of the COVID patient, but I think what is a huge issue that needs to get addressed if your city or hospital has not encountered this problem yet. One thing we are used to in this area dealing with natural disasters like hurricanes and peaks in census due to viral illnesses, et cetera. And so no one is unfamiliar with how to work hard or how to get stretched thin. What this disease has brought forth, and I think, again, since we were a little late and everyone here was watching what was happening overseas and in New York, was a tremendous degree of what people are calling pre-TSD, and how to deal with your staff, the nursing staff and the other members of the healthcare teams who have considerable amount of anxiety, both just in terms of a lot of the media talk about inadequate supplies, lack of PPE, are they safe? Are their families going to be safe? And setting up something so that your healthcare team not only is equipped to handle this problem, but is emotionally and psychologically prepared to deal with this, because I think the emotional toll on the staff, I think, is just as great or greater in our situation, where our census is not anywhere near what we're used to. Our ICU team is used to working a lot harder than this, just in terms of numbers. But the emotional and psychological toll is as great as I've ever seen it. Even during times where we've been in natural disaster mode. So I think that's an important thing to take away and make part of your process in terms of preparing for this. I think the other things, like I mentioned before, as we've learned a little bit more, and maybe how we're not jumping toward necessarily intubating everyone right away, we've expanded our negative pressure capabilities. We've doubled the amount. We've turned more than half the ICU into negative pressure rooms, and we're expanding the amount of negative pressure rooms quickly in the hospital, and that allows us to run and operate some of these other modalities a little more safely, and alleviate some of that anxiety with the staff if a patient is on non-invasive ventilation or high-flow nasal cannula, and I think that's been helpful. And then I can't really add anything to the excellent summary that Dr. Varghese had brought out, and we're following those principles. I'm glad to hear him say it, and I was lucky enough to hear from his colleagues and others in New York echo those sentiments, and we were able to put those things into place in terms of that team approach, cross-training, and utilizing other members of the healthcare team that are actually now are in need of hours or don't have as much to do as before. And so we're starting to do that, and we've been doing that as well. And so again, I think all of his comments were well received, and I think we heeded that advice.
Yeah, it's a fascinating commentary that you say there. It's almost, I'm also in a hurricane area being in Florida, and it's almost like watching a slow motion small hurricane coming right towards you. Then there's a little bit bigger one behind that. There's a little bit bigger one behind that, a little bit bigger one behind that. And you know you're on dead eye for it, and there's just no way out for it to get out from under it. So you keep preparing for bigger and bigger, not knowing what is really going to be happen when they all come through one after the other. And it's just been a fascinating thing. We also have a tremendous vacancy in a lot of our ICU because we've almost completely shut down routine cases, and you almost have an excess of staff on one hand, but the stress level of the staff has never been greater. You know, exactly. Before you enter the hospital, you're getting screened, temperature taken, and different things. You don't even know if you're going to be able to come to work that day. So thank you so much for your time and input. Patrick, did you have? Can you give us some of your insights on all of this?
Sure. Well, I'll start by saying I completely agree with what Praveen said and Dr. Matthew. We're in a situation we haven't been in before, although I really like your analogy to hurricanes. We've been involved with those here in Houston and New Orleans as well. And that's how it feels. I mean, I feel like we're prepared, we're getting ready, but I don't feel like we've really had the onslaught that is coming. So we're ready, but I guess I don't really have any more to say than that.
Well, thank you guys very much. I think, Joe, you wanted to bring Dr. Samir back in for a minute or two?
Yeah, we've lost Dr. Samir. So much for telemedicine. So we'll have to address that later. Technological problems there. Listen, I understand all of you are very busy. I will tell you that there is at least 20 questions. So for those of you out in the audience, we're going to take those questions. John and I are going to address them after we've left, so don't leave, after we've let the faculty go. And if there's any question that needs to be asked of one of our faculty, you'll send it to me, we'll give you the information, and then I will forward it to them, and then they can send the reply back, or we'll set some platform up online, whatever the guys tell me that we're going to do. Yeah, we'll figure that out. So let me just say this, if I can. I know all of us are tough people. We live in very rough environment. Medicine is not for the faint of heart, and none of you probably really want to hear this, but I'm going to say it anyway. In my view, all of you on the front lines taking care of these patients are heroes. You guys in New York are especially embattled. You're like the band of brothers in the middle of a war. And but Dr. Matthew, you as well. Patrick, of course, always living on the edge. John, you and your situation. And look, all I can tell you is that I've got nothing but the ultimate of respect for all of you. And I want to thank all of you for being here. Oh, Dr. Samir's back. I want to thank all of you for being here. I am going to let Dr. Samir close out, and then each of you will have an opportunity to say goodbye to our audience, and we'll close it up. Dr. Samir, since you're back, go ahead, and we're just doing some closing thoughts.
Okay, I just want to put my hat off to all the New York guys. They are amazing. They inspire me that they go to work every day doing what they have to deal with. So they are my heroes, and I will say it over and over. I just think we all are here have to learn from this. We take it seriously. All of us has to take care of each other, take care of ourselves. Again, social distancing needs to continue. We need to preach it. People have to believe it. I mean, I'm okay when people want to hurt themselves, but they want to go to enjoy a party so they can hurt other healthcare workers. That's a problem for me. You are going to hurt yourself. You're going to hurt other people. And and really, I have an issue with that, and I'm going to be preaching that strongly. It might not be a popular thing, but you don't have to take care of yourself. Take care of other people. That's going to be my message across. We have to use our technology to help ourselves and help our patients, and not be afraid of any lawsuits or anything. Finally, HHS has wised up that to help us take care of our patients, we're removing all kinds of boundaries. And I hope that continues. We need to be preaching that message. I mean, for the next years, that should not stop after the epidemic is over. Everyone here, please have a happy Easter and stay safe.
Very good. Well, let's start with you. Let's go in the order that we started with. Dr. Varghese, if you'd like to say goodbye to the audience, they can bid you good day as well.
Okay, thanks very much for having me. It was a privilege, and hope we can do it again, maybe on a different topic.
That'd be perfect. Absolutely. And thank you so much for your.
Come and join us in Houston.
Yes, thank you so much for your very insightful, educational, and scientific, real-world clinical experience. It's going to help all of us. Praveen?
Well, thanks a lot, Joe, for organizing this. It was very informative in a way. I learned a lot from our own colleagues here, as well as other places. I think if anybody wants to reach out to us, please do. I'll leave my phone number with Joe, and any questions whatsoever you guys have regarding anything, please do feel free to call us. We will do our best to find the answers for you if you don't have the answers. But stay safe.
Excellent. Thank you. Dr. Matthew?
Again, same thing. Thank you so much for having me, and it's an honor and privilege to be a part of this. Anything we can do to help. Also, I'd echo Dr. Samir's comments. You guys in New York are the real heroes, and we definitely are benefiting from your expertise and having gone through this trial by fire early. And I think everything you guys have done and continue to do is helping people out there. And I think I certainly think. Some of our success is because we've been able to implement from some of the lessons that you guys have learned, and we appreciate you.
Patrick?
Hey, Joe, thanks for putting this together. This was a really interesting show, different than anything we've done before. And I appreciated the expertise you brought in on this whole thing. This was really good. Thanks for watching, everybody.
Thank you, Patrick. And Dr. Samir. Last but not least, by the way, did you ever see my EKG? Because it was being aired telemedicine when we lost you.
I'm sorry, sir.
Am I going to live?
I'm very sure you're very honoring. You're very honored. You're going to live for like ever and ever.
Very good. Thank you, sir. Listen.
Watch memorial.
Very good. Once again, stay with us if you're the audience. John and I will be back after just a few-minute break. Again, thank you to all of our esteemed faculty, and best of luck to everyone. Godspeed, stay safe, and let's circle back and see what we learned in a month from now when all of this is settled down. Thank you all. Yeah, break. Wow, that was an incredible program. For those of you who are still with us, I can't thank all of you enough for watching this program. I think that this was meaningful, that there was some incredible experiences that people had and shared those experiences with us in order for us to be able to learn from them. It takes an army to figure all of this out, and all these different places seeing these different things. So let me bring John back. John should be around, and I've got some questions here. So let me tell you what we're got, and then also, as I mentioned, if you have a question, can you put our contact at perfusioneducation.com up, that email? So if you have a question that you want asked of Dr. Varghese, Praveen, Dr. Matthew, Patrick, Dr. Samir, or John or myself, please send that question to that email that you see, contact at perfusioneducation.com, and we will get that answer to you. So we'll send it to the appropriate person, and I'll add your email address to it so they can either choose to email you back directly, or they can send it to me, and then I will forward it back on to you. I think thumbs up. Oh yeah, okay. And if you're on YouTube, please give us a thumbs up. Okay, I can't forget to tell you that. Thumbs up, subscribe, do all that stuff. But we're not going to talk about that today. I'm over that. John, what'd you think of the show or the program?
Hey Joe, it was fabulous. I've got interested to see what some of our viewer questions are going to be. I have some quite a bit of comments myself. If you're interested in having a little back and forth while we trickle in some of the viewers' questions.
Mm-hmm. Yeah, go ahead.
Well, I sent in one slide just to put up because I wanted to bring up a interesting conversation. If your technicians there can put up the one slide that I sent in to you guys for the purposes of conversation. So this is for people who are watching. We get this question all the time. So, you know, they talk about that this particular COVID-19 is not very deadly. You know, it's not nearly as bad as the SARS was, or MERS, or even H1N1. So here's a slide that I got. It's a very recent slide, and if you look at there, it says on the bottom SARS, and that was back in, I guess, 2003, I guess, and then MERS there at the bottom is about 2012 to 2015. H1N1's not shown on there, but that was about 2008 and 9. And now we have the COVID-19, which is the one on the far right. So what I've written there in red and what the numbers are there, going back to SARS, is out of 8,096 patients that were infected, 744 died. That's an 11%. That's the big red 11 above that. If you look at MERS, okay, 2,494 people got it and 858 died. That's a 34% mortality rate. Now, when you go to SARS-CoV-2, you see there the numbers, and my screen's blocking it, but that is a 2.8% mortality rate. So people say, well, this thing shouldn't be taken so seriously. We shouldn't be doing all this. Yes, the mortality rate is low, but the number of people who get it is many, many, many times higher, and therefore the number of people who are going to die is many, many, many times higher. So there's also the H1N1, which I didn't show, that had a 37% mortality. So these other three that have come before this have had much, much higher mortality rates, and that was one of the things that was so talked about in the media, that this is nothing. It's a very, very low mortality rate. It's lower than this, it's lower than that. But when you have such a high virility and infection rate of a virus such as this, the net is so big and so broad that the amount of people that are going to die are going to be far greater. What are your thoughts about?
Well, John, you bring up some good points, and I think that data is important. I think that the mortality rate associated with seasonal influenza somewhere around 0.1%. So this is maybe not as high a lethality rate or mortality rate associated with it as SARS or MERS, but SARS and MERS were not pandemics. And so I think what is so concerning is that had those become pandemics like this, we'd be in trouble. So I think that this is pretty virulent. People get really sick. Some of them have these cytokine storms. I've never before in my life seen so much medical activity, pharmaceutical equipment, vaccinations, testing, laboratory, all of this stuff, POC, point of care type stuff, like the Abbott product that's going to be out there. I've never seen anything like this before. I've never experienced anything like this before. I mean, the closest thing I have was the H1N1, and that was 2010. And I lived through that, and our system was stressed, but it wasn't anything like this by any stretch. So, SARS and MERS are both more deadly, agreed, but this is a pandemic. It is on every continent. It is in every country, and it has such a long incubation period before symptoms and possibly not even having symptoms that its rate of transmission of being able to be contagious to someone is way higher. And so I think that's a lot of the reason for it. But those are all good thoughts. I agree with you 100%. So has anyone put a known COVID positive patient on pump? I think we answered that. This is Allison Murphy. And if so, were there any physiological changes on bypass that were noteworthy? So I think Praveen answered that question, and he said that they treat everybody as if they are COVID positive. My suspicion, and John, you can elaborate on this, my suspicion is we've put a lot of patients who are COVID positive, and we just didn't know it on pump. In fact, I think there's a lot of people walking around today that will have antibodies that we have yet to identify. So that's my thoughts. John, what are yours?
Yeah, Joe, I spoke with at least a dozen ECMO centers and perfusionists in preparation for today. And one thing that I did get from a number of centers is not so much on bypass, but on ECMO, we do see two things. Well, that's funny. Some centers see the opposite of what some other centers see. But one thing that did stand out is we see a certain amount of vasoplegia with these patients. And then we also see a certain exaggeration of the coagulopathy. And a lot of these patients will have elevated D dimers, which, as you know, is actually an indication of fibrinolysis. And I have one center that has their hemoconcentrator in line with their ECMO circuit, and they kind of use it as a CRT. And normally that'll last 5 to 7 days, and they have to sometimes change this out 2 to 3 times a day because it clots. So some centers have gone to a much elevated anticoagulation scheme with their anticoagulation, even on VV ECMO, which, as you know, a lot of people really push the anticoagulation to a fair minimal on that. And I think we're seeing a little bit of that at our center. What is your experience?
Yeah, no, I think I just would agree with you 100%. Of course, I don't think you should cut a hemoconcentrator into line. I think I'm more of a believer in hooking up technology like CVVH to it. That's just the way I am. But I mean, I think I agree with everything that you said. There is some other questions I want to get to. Bob Peacott. He said, has anyone considered tapping into the many retired perfusionists to help with staffing during the crisis? Bob, believe me, I have. Unfortunately, what happens is, if you're no longer certified, We can't get you privileged. Can't get a state license for those hospitals or those states that have state licensure. I don't know of any state perfusion license that went to the board or to the governor and said, you have to enact this emergency legislation so that we can bring these retired people in that still have skills that we can utilize if this continues, if this really goes south, which should have been done. But that's why we have those organizations. I don't believe it's ever happened. I don't think any of the organizations have addressed this. And frankly, until I saw that thing, I hadn't thought about it from the last time I thought about it, which that was sort of where I went with it, Bob. I just didn't even think about it too much longer because we can't use you, which makes no sense, but that's a separate issue. Vicky. Good. This is a great question. What would make a patient with COVID whose lungs are deteriorating on a ventilator not a candidate for ECMO? Why aren't we hearing about more patients on ECMO? That is an excellent question. And I am going to address that, and I should have addressed it with our faculty. I'm mad that we didn't. I think Dr. Samir said it best. He said, if you think about ECMO, you're already too late. Put it in. You think about it, you put it in. You don't mull it over. Patients deteriorating on the vent, you think maybe ECMO would work, maybe ECMO would be a right choice. Let's see how it looks tomorrow. Big mistake in his view, and I agree with him 100%. Put the patient on ECMO. The problem is that ECMO patients are huge resource utilizing patients. So you've got diminishing space in your ICU. You have diminishing manpower that's being used, basically diminishing in the sense that it's overcapacitated. You only have so many ECMO platforms. There is a shortage of those too. There's a shortage of people like John and I who can do this, but also manage these other issues going on. I think we're not seeing as much ECMO usage, in my opinion, because it's being held off for only those patients who there is a very good chance of long-term survival. I mean, ARDS has roughly a 60% on average. John, you can correct me on this if I'm wrong, but about a 60% survival, which is pretty doggone high. Because survival without it's 0. So there's a real upside potential. But that still leaves 40% of patients who get treated with ECMO for ARDS that don't make it. In some centers it's higher, and some it's a little lower. Patient selection really matters when it comes to ECMO. So I think because this disease is affecting patients disproportionately that are just not great ECMO candidates to start with, that doing that is being reserved for only those patients where there's a really good chance of survival here. Because if we use it on those patients, we're not going to have it for these patients, and it is a very limited resource. So I hope that answered your question. Don, do you want to elaborate on that?
Yeah, Joe, I have a couple things to add there. I think something interesting, and maybe even use the word unfortunate, happened at the very onset of this. I think the data came out of China very early on, and that is, well, we put 5 patients on ECMO and 4 of them didn't survive. ECMO is really not good for this. We're not seeing that, and I've talked to many centers that are not seeing that either. They're seeing success with ECMO. Now, you're exactly right. You have to be choosy with your patients. We've had all of our patients have actually come off ECMO, and we've only had a few, granted. But I've also talked to a number of other centers who've all done just 5 or less, and all of their patients have actually come off ECMO as well. And so I think, and I said this a week or two ago, I think this early stumbling out of the gate that ECMO was just not going to work for these patients is going to be proven one day to be inaccurate. Mm-hmm. You do have to be selective with your patients. We have been selective. That may help, and that helps with general ECMO as well. The other thing that was reported, and it has some merit, is that these patients go into a severe inflammatory response. Then they deteriorate to the point where they cannot be supported on the ventilator. And then we go to ECMO, and then you have a turbocharged SEERS response because you're putting them on ECMO. And therefore, they actually got worse for a while before they got better. And so you have to plan on a 14 to 21 day ECMO run. So if you only have 3 or 5 or so ECMO machines in your hospital, you get very concerned very quickly that you're going to put a few patients on ECMO and they're going to be stuck for 21 days. Now you have the 20-year-old come in who really needs it, and you don't have an ECMO device for them because they're tied up. So I think that was one of the fears. And what are your thoughts about that, Joe?
Yeah, I think I gave you my thoughts, John. I think that patients who are good candidates for ECMO that develop COVID should be put on ECMO early. I think patients who are marginal at best candidates for ECMO under any under just other circumstances should be considered only if I think it's a luxury, because again we have a limitation to what we are capable of doing. In regards to the augmentation, if you will, of the SERS response that you referred to, I think that's very common. We see that a lot. We just take a regular influenza A patient, ARDS. We might even take a patient who has an aspiration pneumonia and they're developing ARDS, and we put them on ECMO. We frequently see them get worse before they start getting better. How much of that is contributed to by the ECMO itself, I'm not 100% certain, and I think it's one of the reasons why Dr. Samir and I, listen, I love and respect him a great deal. He's extremely smart. He's smarter than I am. He's smarter than I'm ever going to be. But I believe that if you put somebody on ECMO that has no already existing inflammatory process, you're certainly going to have one when you do that. So does it augment it? I don't know. It's a good question. It may. But CVVH, everybody keeps thinking that it's just for clearing metabolites like the kidney. But you can use it to really fine tune your fluid volume. These patients seem to do better drier. They just do better. You're removing, because you're using convection, we've discussed CVVH many, many times, you're removing through convective clearance a lot of pro-inflammatory mediators, all the way up to 40,000 Daltons, 50,000 Daltons. So you're removing TNF alpha. It's a very, very good tool that is not understood by a lot of my physician colleagues, if you will. And I use that term, respectfully towards them. I think it's misunderstood. I think molecular adsorption therapy, is very, very important. I think if you can remove these really giant inflammatory mediators that are protein bound with a plasma molecular adsorbing technology, I forgot the name of the company now. I can't think of it. I'll have to think of it later. But there's several of them out there. And I think that technology is grossly underutilized. I think that these nano, yeah.
So I didn't interrupt you, but Dr. Varghese said something very interesting. They have a suggestion box, or he called it a drop box, where you can put in suggestions, or even an article that just came out. And I saw an article recently where they did exactly what you're talking about. They studied their COVID patients. They put them on CRT or CVVH, whatever you want to call it, and they were aggressive removing the cytokines, and they saw an improvement almost right away. Mm-hmm. One of the main goals of putting the patient on ECMO was to greatly decrease the cytokines through CRT. Yeah. And they did a study. It came out not more than a couple weeks ago, it would be worthwhile for someone to research it and find it. Maybe we could post it, where they were able to decrease the inflammatory response significantly through the use of CVH.
Yeah, I think CVVH. Yeah, I think it's a grossly underutilized tool. Now I don't think it's a panacea. I don't think it saves everyone. But anecdotally, I have a lot of experience with it, and I have seen it do some remarkable things. You may be able to avoid the need for intubation. I've actually done that. I've seen where I have actually avoided a patient getting intubated just simply doing aggressive CVVH. You may be able to get them off the vent sooner. You may be able to avoid the need for ECMO. So I think that if we're going to put somebody on ECMO, it doesn't get any more invasive than that. You can't tell me, oh, you're adding another machine. At that point in time, after you've put the patient on ECMO, it's like using an IV pump, an IMED pump. I mean, you know, that's my view, and I'm very passionate about it. I'm very supportive of it. I think we should do it. But I also think we need to look at some of these other novel nanoparticle technologies, like that Bioxytran thing, BXT25. People can look it up, where you have a molecule that's 50,000 times, is it 5,000 or 50,000 times? I can't remember. It's teeny, it's a nanoparticle compared to a red blood cell, and it has tremendous potential. But again, these are experimental and they need to get into the mainstream, but I think that perfusionists should be driving. So like my opening remarks, we need to be driving a more simplified, efficient, and affordable, and that's a real big thing, affordable ECMO circuit that can be used. We need to be driving education for these nurses and not doing, look, I have no problem with Dr. Varghese' idea, and I think it was a great idea for just-in-time training. You can do that when you already have the basic skills. But ECMO is sort of a unique kind of thing. We need comprehensive ECMO ECMO specialist training, even if you don't use it for 2 or 3 years and something like this happens and you've just done simulations or refreshers every year. At least you're familiar, and that's really important. These nurses are really smart. These ER docs are really smart. These ICU docs are really smart. There's just so many of us, John, and that's, I think, my point. Listen, I want to, out of deference, I do want to say this. JCAM 88, although it increases bed capacity, 2 patients per room may increase risk of HCW, healthcare workers getting infected, as the viral load exposure may be higher, as well as the trips into and out of the room by the nurses or the respiratory therapists. That's a very good point, JCAM, and I'll tell you what else it does. What about them reinfecting each other? Is that possible? Is it really smart to put these people together? But then they went on to say, what about doubling up the non-COVID patients to free up rooms? That, I think, makes more sense in my view. John, what do you think?
Yeah, Dr. Varghese touched on that. I think they were just sort of looking into that idea, and they may have tried it a little bit. And I know at our hospital, it wouldn't be possible. The rooms just aren't big enough that I could possibly see 2 patients being in one ICU room. But I think that is a very interesting thought. I don't know how that would work. Are you going to have one nurse watching 2 patients, or you still have 2 nurses? And what is your exposure to the viral load? You understand what I mean? There's some evidence
doubling the viral load.
That says one reason why people get so much more of a worse medical course than others is the amount of viral load that they ingested or were exposed to. So it really poses some interesting questions. And but these guys are on the front lines in New York, where they're seeing 10, 20, 30 fold the patients that a lot of people are seeing. So they've had to think of things way outside the box. Absolutely.
And thank you for that, John. Listen, JCAM also said that the college at University U of M, University of Miami, University of Michigan, probably University of Michigan, did a known COVID patient for emergency, this is a different thing, patients for emergency cabbage, and he said they required pressor support. They used vaso and levo. I mean, I'm not sure, but this is what he said that I thought was important. As of a couple of days ago, worldwide experience, there have only been 131 patients, 89 in the United States, supported on ECMO with only one discharged alive so far per those registries. Well, I mean, not everybody's on the registry, JCAM, so you need to make sure that not, there's, I think, only 60% maybe. I don't remember the number, but it's about 60% of the ECMO places that do ECMO are on the registry. I know our patient is going to be one of those patients, but still in hospital. So, as Dr. Matthew explained, that could be that could be it, that ECMO's not working well in these patients because, as I think you said, mechanical ventilation and proning seems to be more successful. It may be. My opinion, and again, I'm going to have to vet all this out, and it's going to take me a long time to make this, like Dr. Birx is fond of saying, to go through this data in a granular fashion, make the data very granular, and figure out why did we not see the explosion in ECMO that we saw with H1N1. My gut instincts are telling me it is because of the lack of resources. That's really what I believe. But we'll see. I could be wrong. I don't know. We're going to find out, though, over time. John, I hate to tell y'all, but I'm exhausted, and I'm ready to wrap this up. Can I turn it over to you to say goodbye and tell everybody thank you for coming tonight, and maybe even tell them about our next program?
Yeah, thank you guys all for tuning in and listening. It's been great and very educational. And thank you, Joe, for putting together this forum. We are doing, well, Joe, you're doing a COVID 30, I believe you call it, in about 2 weeks, 2.5 weeks, which is actually a 15-day window of time where you're going to have almost daily seminars for an hour or two, centering mostly on ECMO, along with a lot of COVID topics and points, and that the information may be totally different than it is today because it's so fluid and so changing. So people could keep that in mind and see and have their questions ready for that as well. So I just want to thank everybody for tuning in, thank everybody for their questions, and thank our presenters, and thank you, Joe, for having us. I appreciate it.
John, thank you so much too. And let me just tell everybody one last thing, and thanks for bringing up the Corona 30, but April 23rd, 24th and 25th, those 3 days, we're going to be having something other than COVID because the world is still going on, and we're going to have PerfWeb on common youth behaviors with serious societal implications with Tracy Howarth, which is going to be a really incredibly interesting talk. She's going to be bringing in an undercover officer to talk about how people are taking advantage of the online, of course, the expansion of the online. And here we are, healthcare professionals, we have to work. Our kids need to be educated in school. I mean, I don't know if anybody saw the news, but Zoom was hacked, and they're doing a class with kids online, and they're playing pornography. So, there's hacking into these things and doing all kinds of crazy stuff, and the human trafficking, kids being vulnerable. With everything that's happening, they're afraid, they're uncertain about things, and these horrible people are really taking advantage of it. And as healthcare workers, we need to understand what's going on with our children and our grandchildren so that we can help protect them. That is our sole responsibility. I believe I'm right about that. Tammy Sparacino is going to be talking about work-life balance for the perfusionist. We're going to be she's also going to be talking about disasters. Do we take care of a patient, or do you take care of your family? And look, I've had firsthand experience with this. So has Tammy. This is going to be a real interesting discussion. I'm going to be talking on, is a sole perfusion practice safe? We are going to be talking about coronavirus and implications for perfusion by April 25th. We're going to have some more information by then. We're going to talk about ECPR. We're going to talk about ECMO survival with COVID-19, what we've learned. So we've got a lot of work to do to get that data out and figure it out, and then some discussion. So please join us for that as well. John, thank you again. I want to thank our whole faculty, which isn't here. Again, put our email up if you have a question, and please, if you're watching in the audience and I didn't get to your question, please accept my apology. I'm beat. But send an email to contact@perfusioneducation.com. It's right there. It hasn't come up yet. It's coming. There it is. I see it. Now I'm pointing to it. Yeah. Send an email there And I promise you, I will answer every single email, and or get it to the appropriate person to be answered. And that's it. Thank you all very much for joining us today in such a short notice. And it's been great participation. And I just want to tell all of you, thank you again. John, thank you.
Thank you, Joe. Stay safe.
Thank you. Bye-bye. Good night.